As you know, this is a very tricky topic. People think that it is a very easy topic, but it is not an easy topic because what happens, we have to be very particular when we are doing the myomectomy procedure, when we are not doing it, how we are doing it, what we are planning. So these all we'll be discussing later on. Let's start with the case studies. So coming to the first case study, these are all live cases that we have already done in our hospital. So a 32 years nulliparous woman presented to infertility OPD with married life of 6 years and previous one failed IVF. Menstrual history, she had a cycle of around 26 to 30 days and with 4 to 5 days of bleeding with dysmenorrhea. She didn't have any such complaints of menorrhagia or anything. But the ultrasound was suggestive of an intramural fibroid in the fundo-anterior wall of uterus, which was 3 into 4.6 centimeter. She had already undergone one IVF cycle 2 years ago with history of 9 oocyte retrieval, one fresh ET and one frozen ET done, both failed. So now the patient was very apprehensive that these failures, these implantation failures are happening due to the fibroid. So this was the picture. This was the 3D ultrasound that we did. And this revealed 4 into 4.5 centimeter intramural to submucosal fibroid. That is a FIGO location 2. This was distorting the endometrial cavity with endometrial volume of 2.1 mm. So the patient was highly justified in saying that the implantation failures were happening because of this, because this fibroid was indenting in the cavity. This you can see very nicely. So to take it further, her AMH was 2.3. The day 2 FSH report was 4.5. Estradiol was 37. Prolactin 12. She had both sides febrile block and the TSH was 2.1. The semen analysis was normal. So what did we do? After investigating her thoroughly, we planned for laparoscopic myomectomy because this myoma we were not able to, this myoma can't be removed hysteroscopically. So we planned a laparoscopic myomectomy for her. So what all we did, because in this case, we have to salvage the uterus also when we are doing the laparoscopic myomectomy. We cannot afford to have any complication because this uterus needs to undergo conception again. So the surgery has to be completely complication-free and the uterus has to be good so that the patient can further again conceive and deliver a child. So what we did, we gave a GnRH agonist depot 1 month prior to the surgery to avoid more blood loss during the surgery. Now, how we did it? We did a transverse serosal incision kept after local vasopressin injection was given. The fibroid was enucleated, endometrial cavity was not open, and the fibroid was removed by morcellation in the endobag. So the myometric closure was done using Vicryl 1.0 and serosal closure done using Vicryl 2.0 after inverting the edges properly to avoid adhesion formation. This is very important that you have to invert the edges properly so that there is no adhesion formation. The intraoperative blood loss was around only 50 to 1000 ml. So you see how we did it. The laparoscope is inside. We removed it. This is the endometrial area. We didn't open it up. And then we inserted it and we did the suturing very nicely. So coming to the outcome, after 3 months of laparoscopic myomectomy, patient was planned for IVF. Ovarian stimulation was done. And then A2 sites were retrieved. And after 15 days of ET, her beta HCG came significantly raised. And she had 2 intrauterine live uterine fetuses. And 2 female childs were delivered at 34 completed weeks by LSCS. She did not have any complication during the surgery. That is very important. And post-surgery also during her pregnancy duration. Coming to the second case capsule. There was a 28 years old female, married for 3 years, presented with severe dysmenorrhea and has history of 1 spontaneous abortion at 8 weeks before 2 years and has been trying to conceive since last 1 year without success. The menstrual history was a 40 to 45 day cycle with on and off irregular cycle with 6 to 7 days of bleeding with severe dysmenorrhea. There was history of DNC for RPOC after the first abortion 2 years back. There was no significant medical disease and no significant surgical history. So you see, this is the ultrasound picture. It is showing a 3.4 into 3.3 centimeter submucous fibroid. This is also distorting the endometrial cavity anteriorly near the left cornua, and the bilateral ovaries are showing the PCO pattern. So this is leading to her abortions and implantation loss. So in her case also the AMH was fine. She also had the tubal blocks and rest all was fine. So in this case, the patient was planned for laparoscopic myomectomy as the fibroid size was greater than 3 centimeter size we gave daily injection of GnRH agonist for 21 days. And after enucleation of fibroid, endometrial cavity was accidentally opened, which was repaired by Vicryl number 30. I am specifically highlighting this case because if by any chance you are able to, the endometrial cavity opens, then also you're not supposed to be feel very bad about it, because you see in this case already the fibroid is very much into the endometrial cavity area. So there are chances that when we remove it from here, obviously the endometrial cavity will open. So now what will you do when the endometrial cavity will open? You cannot close it like that. So the patient will have scarring or adhesion formation, because if there is scarring or adhesion formation, the patient will not be able to conceive further. So this endometrial cavity was repaired by Vicryl number 30. The uterine incision was closed in double layer. We were very specific about it. Then HSG was done after 3 months, because in this case, as you see, she was having right patent tube and left cornual block. This cornual block was due to this fibroid, because indenting the cornual area, the ostia. So after we removed this fibroid, the cornual block was released. And then we did a ovulation induction and IUI, and patient conceived in 2 IUI cycle and delivered male child at 36 weeks by LSCS. So this case I'm specific highlighting for everybody, because if the anytime because of the fibroid removal, the cavity opens, so you need not worry about it. If you are doing it properly, the patient will again conceive and the uterus is very much viable. You see in this case, we just did an IUI, the IVF was not required and the patient conceived. These are all live cases. You see, this was the way we were doing it. We did it, we gave the incision, and then this opened up because we took out the fibroid in toto. This obviously this cavity opened up because it will open, and then we sutured it.